Very good. Thank you. Thank you so much, Dr. Morong. That was a great talk. Is sleep endoscopy covered under Ohip?
No, it is not. It is not covered.
Okay. Could you elaborate on perhaps the fees that someone may have to pay?
It varies. It varies. It may be. It depends on the facility and the anesthesia as well. So you're looking in the range of 700.
Okay. Thank you. So of all the procedures that you presented tonight, how many might be covered under OHIP? I guess that would be excluding DICE.
Yeah, so the procedures I presented were the diagnostic sleep endoscopy, where you're looking, recording, and analyzing. That's not covered. Therapeutic sleep endoscopy is not covered as well because it's under the umbrella of sleep endoscopy. The radiofrequency of the palate is not either. If a patient needed to have a palate surgery done, right, such as a UPPP or a sphincter palatoplasty, that can be covered if a patient has tried CPAP and cannot tolerate it. But otherwise, in terms of even invasive surgeries for the tongue base or epiglottis, unfortunately, none of these things are covered.
Okay, thank you. So directly to you, Dr. Morong, how does a patient or a dentist book a DICE appointment with you, and what might the wait time be?
So there is no referral. You can contact me directly. And I can put it in the chat box, my email and our fax number, as well as on the website. We do have a website as well. I'll put all of it in the chat box. You can contact us directly by any of those formats or give us a call too.
Okay, thank you. I thought I was doing so well by blowing up the chat box, so I didn't look like such an old man trying to read very, very small font. And the next question is regarding Propofol, and I've just lost my place, so let me play with this and see. There we go. How much does the Propofol affect or alter the true sleep and airway collapse of a patient?
So in terms of the effect on the sleep architecture, what they've shown is that patients who have Propofol on board, they have an increase in their stage 3 or N3 deep sleep, and they don't see REM sleep. In terms of the respiration should not change. Now, with Propofol, we definitely have the risk of giving too much, and therefore your effects, you get a lot of false positive effects. So you do have to have experience with basically titrating to the lowest level of sedation that's possible. So with Propofol, there is that risk. But for example, when I do the sleep endoscopy, we're starting from a very small loading dose so that I can see the process happen before me. So we go through pretty much, it's not true stages of sleep, but we go from a lighter level of sedation all the way down to a moderate level of sedation to be able to see the true effect of what's happening without going too deep with the sedation.
Okay, thank you. Should we as dentists use appliance therapy first or endoscopy first?
So I'm biased. I would always say sleep endoscopy first, but we do have to live within the practicalities that we have, right? For a patient to have sleep endoscopy, it's a process. They need to be taken to an operating room or an endoscopy suite. So it really is based on your judgment. I know that there are other appliances like the Matrix Plus where a patient can go home and have a titratable device at home. Sleep endoscopy is not a replacement for that. It's almost a complement. So if a patient is not able to have that device or you're having trouble titrating a patient, then I would say sleep endoscopy is there. Or just based on your clinical exam, you're not sure if this patient would be a good candidate and you don't want to take that patient through a process and then for both the patient and yourself to be disappointed, then it would be reasonable to say have sleep endoscopy done first, confirm that yes, the airway opens up. And if it doesn't open up fully, at least you can have a full conversation with the patient beforehand to say, yes, oral appliance therapy will work, but it may not be the whole complete package. And a lot of patients who, if you see a patient who's coming for alternatives to CPAP, they understand that. They understand that there may not be one particular treatment that's needed. Their main goal is that you can help them, right? So they would be willing to take the extra step if it means that the ultimate outcome is a higher chance of success.
Okay, thank you. The next question seems to be an outpouring from what we saw with DICE, if I'm understanding the question properly. So let's try this. Does CPAP actually cause tissue collapse at certain pressures? And if so, can or does DICE get involved in CPAP titration during PSGs?
So I'm not sure if I fully understand. I guess the first part was, can CPAP cause collapse?
I think what the question is, in seeing how loose the tissues were when you were going through the maneuvers, and then thinking about air pressure being brought into that airway, is it possible that it's counterproductive, I guess is what the person's asking.
No.
We all understand the high pressure blows everything open. If it was a mild pressure, would it actually be somewhat counterproductive, if you know what I mean?
Now, the purpose of CPAP in general is that you are trying to overcome that patient's critical closing pressure by increasing the intraluminal pressure to stent open the airway. So if you had a pressure that was too low, it's just that you wouldn't have overcome that critical closing pressure, so you would still have general collapse. We wouldn't know if it's at a specific point unless we were doing DICE at the same time that PAP titration is happening, which there are some institutions in the States that do that, but we don't do that here, but that's how you would know. In terms of a high pressure, can a high pressure cause collapse? Yes. So at the level of the epiglottis, that last case that I presented, what the CPAP pressure did was ultimately pushed the epiglottis down, causing the opposite effect, where now the full airway was being blocked off by the CPAP pressure because of that floppy trapdoor epiglottis that was occurring.
Okay, the next is not a question, but a comment. Wow, that was refreshing. Thank you, Dr. Morong.
Oh, thank you.
So there you go. Next question, is Inspire available in Canada?
No, unfortunately, it's not. We have tried, but to get through Health Canada, it's not happening anytime in the near future. Even the company is not very motivated to go through the hoops that would be needed to try to get it approved here. So at this point, it's not.
Okay, and another kudo, not a question. That was an excellent and very informative presentation. Thank you, Dr. Morong.
Oh, I'm glad it was of some use to everyone.
Yeah, you've got two fans for sure. Next question, who can refer you patients for the procedure? Does it have to be done by a referring physician, or can a dentist do it directly?
Once it's sleep related, definitely a dental professional can do the referral. So I've just put into the chat box our website, the email, fax number, and I'll put our phone number as well. So you could use any of those formats to contact us directly.
Okay. I presume this question's related to DICE as well. Is the procedure available outside of Toronto, or I guess the GTA?
So there are three of us who perform this procedure. There's Dr. Rotenberg in London and Dr. Chow. And I apologize if I'm mispronouncing his name. I'm having a mental block, but he is in Alberta. I will look that up to make sure I get his name correct. And I will put that into the chat box. But in London, and I believe he's in Edmonton, it is done.
Okay, next question. How long does the radiofrequency procedure of the palate last? Are there any downsides of these procedures in terms of speech and swallowing? I'll let you answer those two, and then there's a couple subparts. How long does it last, and any downsides in terms of speech or swallowing?
Okay, so with the radiofrequency of the palate, done by itself, there isn't a lot of information on it. I said that, when I spoke about that case, I am very conservative in treating patients with radiofrequency of the palate because you're looking at conservative effects. You're not doing anything that's very invasive. So it's a low risk, potentially low reward that can happen with it. In terms of long term, all I can go on, because there is no real literature on the long term data for radiofrequency, is based on experience primarily from before, is that patients who have gone basically 6 months to a year have been doing okay. But longer than that, it's hard to say. But it really is, I would say, more so a treatment that's an adjunct versus a treatment that should be on its own. When it comes to the radiofrequency of the turbinates, there's a little bit more data on that, where patients at the 2-year mark and the 5-year mark have shown success ranging from 68 to 75% for those patients. But again, and I'm going on a sidetrack here for the turbinates in case anyone was interested. Turbinate surgery in general, every patient should know that the risk is that it may not work because we're not actually removing tissue. No matter what type of turbinate surgery you do, we can't because there is a function for the turbinate. So all we can do is shrink it, and then it's up to the patient as well to commit to doing saline rinses, maintenance to help prevent that swelling from returning. With the palate, we do have age, loss of tone. A lot of times myofunctional therapy, I would say, is a key part of doing any sort of palate modification. That patient needs to have that tone overall improved, because otherwise, it's almost a Band-Aid effect. So I would say if you're going to have a patient who is doing a radiofrequency palate or any palate procedure, that myofunctional therapy should come right along with that to help prolong the effects.
And just to show you, Dr. Morong, how much we're on top of things, we actually have a speaker booked in June on myofunctional therapy.
Oh, perfect.
And you probably know who he is because he works not far from you.
Okay.
Back to finishing up this long question about radiofrequency. So if you use this procedure on a younger patient, does the scarring affect the patient's quality of life in later years?
We don't have enough long-term data on radiofrequency. If the only way I could make it analogous to the more invasive palate procedures, younger patients having that would not have issues with, and I didn't answer the first question in terms of speech and swallowing. No, there are no issues with speech and swallowing during radiofrequency. If you're doing more invasive palate surgeries, then you do have a higher risk of getting a globus sensation, we call it, or you feel like even though part of your uvula may be removed, that you're still feeling it there, for example. Some patients, a risk is that you do have velopharyngeal insufficiency, which is where you're eating and some of the food or drinks come up through the nose. Should be temporary, but there's a chance it can be permanent. Any immediate scarring or stenosis that happens from surgery, that's a complication that's happened from surgery, and usually that happens pretty much very immediately in the near immediate post-operative course for that patient. Long term, there should be no stenosis or scarring. What we would more see is that the tissues that we have tightened have become lax, and again, that's where the myofunctional comes in.